Good afternoon. I'd like to give you the warmest welcome to this 8th SLAGO meeting, Latin American Symposium of Oncology, Gastroenterology. Today we will speak about metastatic colon cancer, specifically focused to peritoneal carcinomatosis. I am head professor of surgery in University of Chile, director of the surgery department Salvador Hospital in Santiago, organizer of the American College of Surgeons, and member of the Chilean American Academy of Surgeons. Today with me have Dr. Horacio Lopez, oncology surgeon, chief for gastroenterology department of Cancerology Institute of Mexico, president of the American Association of Cancerology, and researcher of the National Institute System, level 1 researcher of the National Medical Researcher. He will head the Q&A session and he will introduce all the speakers. Next, the first part of this afternoon, we'll have the first presentation is Understanding Peritoneal Disease, Physiology and Pathophysiology, in charge of Dr. Alberto Takahashi from Oncology Surgery of the Autonomous University of Mexico from Mexico City. Second, Dr. Martín Eleta, Medical Director of IMAX Diagnostic Center of Images from Argentina, who will introduce imaging study of peritoneal carcinomatosis. The third part is surgical considerations of the resective surgery by carcinomatosis, HIPEC and PIPAC. This will be in charge of Dr. Silvana Cavalieri, an anesthesiologist from Las Condes Clinic and Luis Calvo Maquena Hospital, Pediatric Hospital, both in Santiago. And she's from the University of Chile and past president of the Anesthesia Society. She has dedicated most of her activity in anesthesiology to transplant, solid organ transplant and complex surgeries. After her talk, Dr. Jesús Esquivel will speak about a critical view on HIPEC. He is president of Regional Perfusion Hypothermic Interventions, and he's head of the American Association of Peritoneal Tumors. And the presentation will close by my talk, Mario Uribe, PIPAC in program, indications and results. So we have excellent level invitees, and afterwards, Professor Horacio Lopez will head the Q&A sessions. I'd like to thank all participants and all of you as an audience, and most of the people that will head this panel. I know them personally. We've shared webinars, seminars, meetings, etc. Welcome you all.
Hola a todos.
Hello everyone. I am Dr. Alberto Takahashi, surgeon oncologist from the Cancerology Institute in Mexico. I'd like to thank the organizing committee, especially Dr. Jorge Gallardo, for extending the invitation to open the module of metastatic colon cancer with this very interesting talk on peritoneal disease, its physiology and pathophysiology. It is very interesting to speak about peritoneum, to know that it is a serous membrane of connective tissues with two layers, parietal and visceral layer. One covers the abdominal wall and the other one covers all the abdominal viscera. It's originated on the mesodermal layer. It is large, 1.7 to 2.1 square meters, and the function above all to produce a peritoneal fluid that lubricates all the abdominal organs to decrease friction among them. And it's also a semi-permeable membrane that diffuses passively solutes and ultrafiltrates water. And not only that, it has also pathogens, because the peritoneal fluid will have immune cells such as macrophages, lymphocytes, mastocytes that will help clean that abdominal cavity. Irrigation is given by the peritoneum through the arteries in the abdominal wall. The visceral peritoneum receives its irrigation through all those arteries, celiac trunk, superior and inferior mesenteric arteries, and pelvic arteries. Innervation is through the afferent somatic nerves, so they transfer pain sensitivity, and the visceral peritoneum has non-somatic nerves that respond to tissue tension or ischemia. Lymphatic drainage is very interesting, especially on the parietal area, directed towards the vessels in the abdominal wall. The visceral peritoneum will drain and follow all the lymph nodes from the corresponding organs. In 1863, von Relenhausen stated that there are modified lymph organs that will eliminate particles of the peritoneum and will take back to the lymphatic tissue through the later elimination. And specific to the peritoneal membrane, we will see first that it is composed by mesothelium, which is the more superficial area with a monolayer of mononuclear polygonal spiculated cells where the peritoneal fluid is secreted, and it avoids the passage of larger molecules larger than 30,000 Daltons. Produces the peritoneal fluid, and it's a barrier against the pathogens. This is a monolayer of cells rest on the basal membrane with a thickness less than 100 nanometers, containing the cellular matrix, collagen 4 laminin, and gives support to the mesothelium. And under that, we have the submesothelial or interstitium stroma that has collagen type 1, laminin, fibronectin, fibroblasts, adipocytes, vessels, etc. Going into the specifics, we see that the mesothelial cell originated in the mesoderm, measures approximately 25 microns. It's a flat polygonal cell with spectacles on the apex. It has an epithelial and mesenchymal component, and it expresses cytokeratins, cell adhesion markers, diamantine, desmin, fibronectin, and inicaderins. And you see the intercellular junctions have different forms. We see in basic biology, tight junctions on the apical part and through the cytoskeleton, which would be what gives the structure to the mesothelial cell, which is tightly joined to the different mesothelia cells. The desmosomes and then the integrins or hemidesmosomes will maintain stability with the basal membrane, and between the mesothelial cells we would see channels that will transfer solids. In terms of peritoneal metastasis, we have three routes of destination. The first one and most studied is the transmesothelial route. The second one is the translymphatic route, and then from superficial growth, which is the one we will find in mucinous tumors. Speaking about transmesothelial metastasis, we can see that this starts when the tumor cells start changing and it starts to be exfoliated or released. And we see these tumor cells have changes in cell adhesion in the poorly differentiated cancers. We have seen a reduced expression of claudin or E-caderins that are transmembrane glycoprotein that keeps the cell adherence to the basal membranes. And if this protein has any change, we will see peritoneal fluid into the cavity. When the tumor cells migrate on the peritoneal surface, they will adhere to different areas of the mesothelium using integrins. These, you can see in the diagram, will interact with all the substance in the mesothelial cells, and they will generate inflammatory factors for them to expose the basal membrane. Going into specifics, you can see in the diagram these different junctions. We have two that are to point out. First, the tumor cells can express the antigen of CLE-Lewis antigen, which is a carbohydrate expressed in the tumor surface, which is connected to E or interact with the selection of picaderine, allowing adherence of the tumor cells and release of inflammatory factors. We can measure this antigen with the monoclonal CA 19.9. antibody. So there is this antibody will be elevated in the case of a tumor. In ovarian cancer and mesothelioma, we will see an increase in CA125, which is a glucoprotein expressed in the tumor, will be joined to mesothelin, increasing the adherence of this cell, and we will see an increase in CA125. After the tumor cell is adhered to the basal membrane and contracted the mesothelial cell, the basal membrane is exposed, and through that inflammatory reaction, we can appreciate the invasion of the tumor cell towards the basal membrane to reach the interstitium. We can see the participation area of different substances or additional molecules to continue the interaction with the basal membrane and the invasion by the tumor cell. Finally, when the tumor cell reaches the interstitium or the submesothelial stroma, this is where the tumor cell, through the movement, which is described as an amoeboid movement, reaches the interstitium or the submesothelial stroma. Why there? Because there the concentration of oxygen is sufficient for the tumor cell to survive. Unfortunately, in the interstitium, there will be no diffusion of medications, only oxygen, and this is why our chemotherapies do not reach this area. So the goal of the tumor cell is to grow in that environment and then adhere to the different cells to reach the different areas to invade. Once the tumor cell is in the interstitium, it starts to replicating and proliferating, expressing a series of growth factors against receptors that are in the interstitium, perpetuating the tumorigenesis. So once they grow, they require more oxygen, more nutrients that are not enough in the interstitium, and this is where angiogenesis is activated. To summarize then, we have the mesothelial cell in yellow, the basal membrane, the black line, the submesothelial stroma, the interstitium, and the capillary area. We have the free tumor cell that adheres to the mesothelial cell through different factors between the interaction of adenosines, integrins, etc. We see the mesothelial cell contracts, exposes the basal membrane, the tumor cell invades the basal membrane, and at this point in time, it receives the oxygen from the interstitium and then increases in size, the tumor cell, and more tumor cells that are free reach this area, continue growing using the oxygen in the interstitium or submesothelial stroma. And we apply chemotherapy at this point in time. Since the size of the molecule does not diffuse from the capillary area to this interstitium, these cells cannot be killed. But once the clone has a larger size, larger than 100 microns, angiogenesis starts to be generated. And with angiogenesis, the chemotherapy substances can reach these clones and can destroy this cell. And this is relevant to clones. And all the free cells, the small cells that are destroying the membrane, the basal membrane, and are using the oxygen will not be destroyed by systemic chemotherapy. And at this point, peritoneal chemotherapy can have a positive impact for that bidirectional chemotherapy. Remember, this could be normothermic, hyperthermic, or PIPAC. The goal of this thing is to attack the cells and from the capillary to the interstitium. Speaking about the next form on peritoneal invasion is translymphatic invasion described recently by Dr. Johnny Mura, where here the tumor cells look for those lymphatic vessels that are modified with holes or stomas, and can be found in the epiploid appendix, in the falciform ligament, in the intestinal mesenterium, in the parietal peritoneum, in the subclinical area, and the milky spots that we can see in the lymphoid tissue. We can see here the action on the diaphragm. We can see the tumor cell detected in the lymphatic stoma, and through aspiration with a negative pressure on the thorax, these tumor cells can go inside the lymphatic system, and from there they can invade the pleural cavity, or they can move towards lymphatic vessels that are larger, reach the thoracic duct to produce tumor invasion. The final invasion is superficial growth. We can see in the image this type of dissemination occurs in mucinous metastases. These are very large tumor cells covered by mucin that do not have the ability to invade the interstitium, but they do have the ability to develop proliferation and angiogenesis on top of the mesothelial cells to stimulate angiogenesis and invade as a mucus the peritoneal cavity. From this diagram, you can see this mucinous clones cannot go inside the interstitium, but they can proliferate and generate angiogenesis to continue their growth. We can conclude that it is fundamental to know the anatomy and physiology of the peritoneal membrane to be able to understand the route how tumors disseminate and metastasize. So this complex interaction between the tumor factors with the mesothelial cells to expose the interstitium, which is rich in oxygen and nutrients, and help the tumor cells to proliferate. Undoubtedly, treatments, peritoneal treatments such as HIPEC, PIPAC, and normothermic treatments will complement or adjuvate systemic treatments with the goal to decrease the tumor load that we have on the peritoneal side, while the systemic chemotherapy does it on the capillary side through those clones that already develop angiogenesis. Thank you very much for your attention.
It is a pleasure to say hello to you virtually. My name is Martín Eleta from Argentina. I am a specialist in imaging diagnosis. I will speak about imaging study of peritoneal carcinomatosis. Let's remember basically that this complex serosa that covers the walls of the abdomen and pelvis and most organs is divided in two main spaces: the supramesocholic space and the inframesocholic space, divided also in right or left. In the supramesocholic space by the round ligament, and in the inframesocholic by the meso of the small bowel from the Treitz angle to the ileocecal junction. The circulation of fluid, this is important to remember, because with this information, we will find the different stations of peritoneal dissemination. This is the cytic fluid that moves following gravity and following the negative pressure of ventilation that causes its descent in the cephalic direction. This is the same circuit followed by peritoneal metastasis. The pathways for dissemination have to do with direct invasion, intraperitoneal seeding, hematogenous, and lymphatic dissemination. At the moment of diagnosis, 10% of colorectal tumors present peritoneal carcinomatosis, and it is the third frequency after liver and lung. PCI, or the peritoneal cancer index, is the method used to quantify the extension of peritoneal carcinomatosis, and it is performed based on the distribution of the lesions in every one of these quadrants, plus the mesocolon of the small bowel. A PCI of 20 or more is a contraindication of cytoreductive complete surgery combined with HIPEC. Based on an adequate selection of patients, and please take a look at the global or overall survival curves, which depend on patient selection. The main signs in imaging have to do with the presence of ascites. 1 out of 3 patients presents this sign: thickening of the bowel wall with distortion, thickening, or obstruction of the bowel, tumor invading neighboring organs directly, ovarian lesions, peritoneal enhancement irregularity of the liver surface, involvement of the omentum with the presence of the alteration of the omentum or nodes or masses, calcifications which may be associated to a mucinous component of the tumor if they are present before treatment. In colorectal cancer, the most affected places are those affected by gravity, the pelvian cavity, and the right hemiabdomen. We should consider that all of the imaging modalities underestimate the real possibility of having peritoneal carcinomatosis. But even so, imaging methods are adequate to use non-resectability criteria. For example, the vascular involvement in the hepatic ileum, as shown in the example, with involvement of the portal vein, or the mesenteric root, or the joint involvement of the stomach and colon, or of the total thickness of the diaphragm. Also, disseminated gastrointestinal involvement and important pelvic involvement, including the bladder. And as mentioned before, a PCI index equal or greater than 20. All of these are a criteria that do not allow for cytoreductive surgery. Computer tomography or CT scan is the preferred technique. It is economical, fast, standardized. It may be of the whole body, and it should be to detect distant lesions, especially in lung and liver. It may be multiplanar, different from the old CT, which gives anatomic detail, and it is easy to interpret considering also MRI. Disadvantages are the low detection of small lesions having to do with a complex anatomy, the density, which is similar and does not allow the differentiation with soft tissue. Sensitivity may go from 25 to 100% and specificity 78 to 100%. Lower sensitivity has to do with small lesions under 5 millimeters or located in certain parts, such as the root of the mesenterium, the minor omentum, the left hemidiaphragm, or the serosal surface of the bowel. About contrast, we may use arterial phase after intravenous contrast or oral, but it has the complexity of hiding other features. An example here, a patient with a suspicion of progression of disease of colorectal cancer, and we see an broad involvement of the peritoneum, the major omentum, the mesocolon in the transverse section. MRI is an excellent technique, giving great functional and morphological information. We are speaking here about diffusion. What it shows is the restriction of diffusion of water through tissues because of the presence of tumor, which is hypercellular. In this case, it lights up in diffusion when is not lighted up in the ADC map of that sequence. MRI has a better resolution of contrast in tissues, which is something hard for CT scan. Here we have a better resolution of tissues. It may assess the water content of tissues better. The presence of mucin can be detected. Smaller lesions may be detected. It is also a multiplanar technique and differentiates better scar tissue compared to viable tissue. And the addition of morphologic sequences and diffusion-weighted images improves detection of peritoneal carcinomatosis. These publications mention a lot of figures, but basically the concepts have been summarized as I mentioned. Here is an example showing a patient with abundant acidic fluid in all of the peritoneal cavities and not in the retroperitoneum clearly. And we observe broad involvement of the peritoneum. Take a look at this restriction of the DWI and is hyperintense in this vision, involvement of the omentum and the mesocolon of the different structures, and also an ovarian nodule to the left, which is restricted in terms of diffusion, and right pararectal nodule as well. What are the disadvantages of MRI? This has to do especially with the fact that it must be performed in expert center that works with the pathology, works with adequate sequences. It has a long learning curve, and this is a technique that is also operator dependent. And if poorly performed, we miss the opportunity of detecting the extension of carcinomatosis, and it may impede adequate decision making. The studies that have been published consider few patients and are retrospective. And on the other hand, an MRI requires a translator. This has to do with the possibility of having a good report, or the presence of a physician in a multidisciplinary team to be able to convey the findings. It's not easy because of these reasons to interpret the image by a physician who is not well trained. It is also difficult to detect micronodules at the millimetric level, miliary seeding, and we should also consider the presence of movement artifacts, which may worsen the image. It may be patient movements, peristalsis, or respiratory movements, and all of this may attempt against maybe against an adequate diagnosis. Here, visualization is impeded by breathing movements. The lesions are present, but it's difficult to detect them using this sequence in the upper part of the slide. PET-CT. This is a technique that plays a very important role in detection of peritoneal carcinomatosis and also the extraperitoneal dissemination in these patients. PET uses a radiopharmacology, and the one that is most used is FDG18. This is marked glucose. Indications have to do with increase in tumor markers, negative or non-conclusive anatomic imaging with suspicion of peritoneal dissemination. It assesses at the same time the involvement of abdominal and pelvic cavities and distant metastases. It is a very useful tool for the evaluation of candidates for surgical cytoreduction plus HIPEC. It has a better diagnostic precision and agreement between different observers and better correlation with surgical findings. The patterns we may find are diffuse, focal, and mixed. Here's an example. A patient with a history of rectal cancer that presented an increase in CEA marker. CT scan was negative. Here are the images. It's really difficult to determine if there is another lesion. Here, focal uptake agrees with a thickening, and this is an implant. In whole body image, we see other implants that were not detected by CT scan. The main advantages have to do with this being an anatomic and functional method. Let's remember that CT scan should be diagnostic. We should use oral intravenous contrast and thin slices to be able to give data and visualize the morphologic lesions. There are different radiodrugs, some of them under assessment currently. The one that is most used is FDG18. This is the best method to assess the extraperitoneal dissemination. It is superior to CT and MRI in nodes that are adherent to the gastrointestinal serosa, which are not seen in the first reading, and it can also detect second tumors. Disadvantages have to do basically with false negatives because of small sized tumors under 5 millimeters of diameter. Tumors with low cellularity, such as mucinous tumors or tumors with low glucolysis. False positives may be inflammatory processes and also intestinal activity that may be physiological or inflammatory and may impede the visualization of implants in the bowel walls. There may also be urinary activity of urinary excretion in the ureters and bladder, but this is easy to solve together with CT scan. A meta-analysis shows a sensitivity of 84% and specificity, globally speaking, of 98%. These are several studies showing, once again, figures I will not cover, but that show part of what we mentioned. This is an example. A patient with ascites, CT scan is performed. We observed abundant ascites without nodes, without the primary tumor. PET-CT using FDG allows visualization of the primary tumor, which is a transverse colon tumor with implants in the transverse mesocolon and associated with a major gastric curvature. And the splenic ileum as well, and in the pelvis, in the sigmoid colon mesocolon. PET is the examination that can detect better the distant lesions, which changes management in 20 to 30% of patients with colorectal cancer. It especially detects extrahepatic lesions better, especially the peritoneal ones. The pre-surgical role in high-risk patients is important. It is to detect distant metastases that exclude patients in whom these procedures may be inadequate, and it may complement MRI in the detection of liver lesions. Here's an example using a different radiodrugs, in this case, gallium and FAPI, an inhibitor of the protein that activates fibroblasts. Some tumors which do not have a high FDG uptake may have a significant uptake of a high uptake after FAPI. This is a gastric cancer to the right with an extensive peritoneal involvement shown by FDG, but shown much better using gallium FAPI. Now, to end, final considerations. All these methods play an important role in the detection of peritoneal lesions. We should consider that there is an underestimation of extension. However, they have the capacity of determining that some patients are not candidates for cytoreductive surgery, especially we have the problem of miliary dissemination. Diffusion in MRI may play a role to be able to precisely detect small lesions and detect mucinous lesions and hypercellular lesions. FDG PET is superior in the detection of extraperitoneal lesions and also peritoneal lesions. In our experience, this is the best method when you suspect peritoneal dissemination. In the future, the possibility of having new radio drugs such as gallium FAPI and other aspects for the future are the use of artificial intelligence and radiomics, which is considering all of the data from digital imaging that can be analyzed and give important data that correlate with clinical aspects. This is also part of the use of imaging diagnosis. All of this in the necessary and important context of multidisciplinary committees. Thank you very much for your attention.
Hi to everyone. My name is Silvana Cavalieri. I am an anesthesiologist physician from the International Hospital in Chile. And in the next few minutes, I will speak about the surgical management of the patient with peritoneal carcinomatosis submitted to cytoreductive surgery or CRS and HIPEC, intraperitoneal chemotherapy. Those are the concepts that we will review. HIPEC and cytoreductive surgery are considered the treatment standard for those patients with peritoneal carcinomatosis, such as ovarian, gastric, some colorectal cancers, and with pseudomyxoma. Both together improve average survival up to 5 years. Nevertheless, in the last years, these concepts that were very established have been placed in doubt, as you will see in the later conferences. The goal of cytoreduction is to eliminate macroscopic disease through the resection of the whole visceral and parietal momentum. HIPEC on its side is the local administration of high dose of chemotherapeutic drugs at high temperature. This procedure is used then in peritoneal carcinomatosis. The question that we can ask is why intraperitoneal chemotherapy instead of intravenous chemotherapy? Traditionally, in the case of ovarian cancer, administration of intravenous chemotherapy was the way to go, but in the 60s, intraperitoneal chemotherapy was introduced with the goal of controlling malignant ascites or fasciitis. And it was seen at that point in time that cisplatin was eliminated gradually from the peritoneal cavity. So a high concentration of this drug could be administered intraperitoneally without this resulting in a systemic overdose. And the other question that we can ask ourselves is why high temperature intraperitoneal chemotherapy? And this corresponds to very old observations from the 19th century, where they found an association between induced fever or spontaneous fever and remission, partial or total, or even in the absence of some types of cancer. And later on, studies demonstrated that high temperatures can damage and kill cancer cells without affecting the normal tissue. So the reasoning behind using intraperitoneal chemotherapy at high temperatures is that the high temperature favors local control of the disease and minimizes the effects of systemic toxicity of the drug in this administered only by intraperitoneal route. So cytoreductive surgery plus HIPEC would produce a synergic effect in the destruction of the malignant cells. There is another concept that are relevant for a treating physician that we have seen, and we should be conscious that they exist, which is called the PCI, the peritoneal cancer score, and fitness of cytoreduction. These have been in the last decades in terms of the continuous development of the cytoreductive surgery and HIPEC in peritoneal carcinomatosis. How do we do this procedure? Of course, there are different procedures according to the different centers, and these experiences have been published in the literature. What is known is that both procedures produce a series of physiological and pathological changes that have an implications in the surgical care, and this is why this is so important, and some physicians consider these very invasive techniques may not have the effectivity that in the beginning was stated that they had. In the case as our center where we review the procedure, how do we go about it? First, the patient should have an appropriate indication after going through the oncology committee, and it is considered that the patient has to be rehabilitated. What does that mean? In conditions to be facing through this large surgery with pathophysiological and physiological implications, this requires of course, then an adequate assessment from surgery and anesthesiology, and of course, implying a good communication between the two physicians. And it will require the adequate infrastructure and the human team, and that is very close related. It needs a special operating room, and the team should know all information. It is also important to fully inform the patient and his or her caretaker about the surgical indication. Of course, the surgeon has done this, but we as anesthesiologists should report this indication, how the peri-surgical period will be for the patient, all the implications in terms of bleeding, inflammation, pain management, post-op mechanical ventilation that could take a few days. The need or eventual need to really intervene due to surgical complications, the patient should be cautious that this is a major intervention and it could have complications. The patient should know about this, should tolerate surgery that eventually will have many days of intensive care management. When we speak a patient being rehabilitated or prepared to face this surgery, ideally the patient should not be undernourished or with hypovolemia. We should not be anemic. It should have an appropriate diagnosis, and if there is a previous history of thromboembolism, this should be approached, and also prevention of future thromboembolisms. Of course, coagulation studies are very relevant in terms of coagulation tests and platelet count. This due to in many of these patients, they have had a prior chemotherapy that affects the number of platelets, and this becomes very relevant when we speak about regional anesthesia. And this anesthesia, and the one that we use for this, with more effectiveness in posterior management of the pain after surgery, is the thoracic peridural anesthesia. If not, we use intravenous morphine, and we will speak about that. In terms of infrastructure and the human team, what do we require? Of course, oncology support. Oncologists should be conscious and know about this procedure and the doses and the most appropriate drugs for this type of procedure, and know are with all the instruments and facilities with safety for the operators, because we are speaking about chemotherapeutic drugs in high concentration that need a management and protocol of elimination that should be complied with. We also need an extracorporeal machine to administer continuous HIPEC, laboratory and blood bank support for the perioperative period, posterior support from the intensive care units, and known protocols in such a way that always this is developed in a standard fashion, so because that will produce a better benefit for our patients. A diagram how to go about this is, you can see here, we start with anesthetic induction. This will we will put the patient to sleep. We will have invasive monitoring, because we will always need a central venous catheter, a Foley catheter, because we have a high complexity surgery scenarios. We need to maintain or keep the temperature normal or high. At this point in time, we put a peridural anesthesia with the patient awake still. And we do a frequent metabolic and hematologic control during the surgery and prior to starting the surgery. At the time of sample rejection, we know that the bleeding can produce a huge mobilization of fluids, and this surgery requires intense pain management due to the bleeding and pain management. The patient can go into hypothermia, so we should avoid this. And then we have the HIPEC, the installation of the circuit. We do not desire or want a huge difference between the temperature in the patient and the fluid that will be perfused in the peritoneum. Ideally, the patient should be with his body temperature around 36, 37 or a little more degrees. In the final stage, the circuit is installed. The function is analyzed to work correctly. Personnel is protected. There is continuous vigilance of the process, the time lapse, and that will be 60 or more minutes. The fluid should be circulating with the oncology or chemotherapeutic drug in place, functioning correctly. We check the temperature of the patient getting higher. We do not want it higher than 39, 40 degrees. And if that is so, we need to cool down the patient. And in this case, we use the convection coolants. And remember, in the cytoreduction phase, there is blood loss, there could be coagulation disorders, metabolic disorders. So we will frequently and permanently control the patient with blood tests to be able to control these disorders that have been identified and observed with this methodology. Anemia, hypovolemia, and gases, and we measure albumin levels to maintain bulimia. HIPEC, you can see the diagram here. We have an extra circulatory membrane. We use a roller pump, as you can see there, that is used for cardiac surgery, same thing. And in recent years, we have these pumps that are designed specifically for this type of intervention. During this stage, it is very important to check the safety of the procedure. The personnel has been educated and trained on the safety. You can see all the equipment that they use in terms of clothing and eye and face protection. The operating room should have HEPA filters and air conditioning. And in the beginning, this was very difficult, but nowadays this is a routine intervention, and it is a safe procedure if it is done correctly. This is the pump that we have available for us. You can see it there, and we rent it each time. Initially, the technique was in Coliseum. What does that mean? An open technique. You can see the picture here. The surgeon is permanently manipulating the peritoneal fluid to certify that there is a circulation throughout the peritoneal cavity. All the mentum has been resected already, and all the visible cancer areas have been resected too. And here we can appreciate the surgeon adequately protected, checking that the effectiveness of the procedure and circulation of the chemotherapy drug reaches all the areas of the omentum. Lastly, we've been introduced the close technique. So HIPEC is done at the end of the surgery with the closed field. You can appreciate here, this has certain advantages. There is less loss of temperature, but the disadvantage is that we are alone in the operating room because before the surgeon remained in the OR because he had to check the process. Now everyone leaves and only anesthesiology stays in the room together with the person that is in charge of the pump. 60 to 90 minutes of loneliness inside the operating room. What are the drugs that are used in this procedure? Depending on the type of cancer, oxaliplatin, mitomycin C, all these drugs are toxic. You should know their toxicity. You should know the drug, and you should be in continuous communication with the oncologist to know what type of reactions can appear during the drug administration, because intravenous drugs are also administered. The most frequent complications or events during this procedure are blood losses, which could be 1 liter, 1.5 liter, and many of the patients will go after this procedure to the intensive care unit, ICU. 80% in our observations, 75% of the patients will be extubated later on. And the idea of the patient when intubated is to give them comfort and manage pain in the optimal fashion. Regional anesthesia in this area has a relevant role. It's considered that pseudo-reductive surgery plus HIPEC is the most painful than thoracotomy interventions, and the use of thoracic peridural anesthesia will require the opioid requirement and improve the patient's comfort. The recovery will be better, and more we are trying to use this type of anesthesia unless the platelet count is too low or there are disorders of coagulation being an intrinsic of a sphincter pathway. Most of the patients submitted to this procedure, we try to have thoracic peridural anesthesia. The patients are left for 2 or 3 or more days in the program of pain management that we have available at our clinic. The patient is adapted many times a day to anesthesia to manage pain. Today, what we use is the closed technique because it will produce the surgical time and the loss of temperature. HIPEC management has been optimized in the intraoperative with better pumps, better drug dose, better equipment. We have been improving our management of the patient with less operative inflammation. And of course, all of this has required a learning curve. Recently, there are new techniques, the PIPAC technique. This is an operative technique for invasive massive ascites. And what is the most important concept is that basically what is done is aerosolize the chemotherapy drug within the abdomen without doing any resection. And the most relevant consideration here, aside from giving an adequate anesthesia to manage pain, placing pumps that are outside the operating room, so surveillance is being done through windows and monitors that we can survey outside from the operating room. And the other consideration, there will be a massive release of ascites. This could generate a hypotension or hemodynamic event that we need to know how to manage. To summarize then, in relation to complications, events intelligence, or cytoreductive surgery and HIPEC, we can say in the pre-op it is important to do an adequate assessment pre-surgically, and the patient should be habilitated in terms of nutrition, hematology, and respiratory parameters. Within the operation or surgery intraoperatively, we need to hypothermia, and depending on the moment of the event that we will have to be informed of all hemodynamic changes that occur, vasodilation, bleeding, coagulation disorders, selection of reposition fluid. It's also important. In our case, we use albumin, and consider the length of the surgery that could be long in terms of support points, and also to consider supporting areas in the bony areas of the patient. In post-surgery period, we did appropriate anesthesia, inflammation management, early detection of complications, coagulopathies, pleural drainage is left in place as a prevention management, and surgical complications should also be assessed. Thank you very much for your attention.
Good afternoon, ladies and gentlemen. It is an honor for me and a pleasure for me to be here in this very important event. I would like to thank the organizing committee for their kind invitation, especially Doctors Mario Uribe and Horacio Lopez. I have been assigned the critical vision of HIPEC. During the next 15 minutes, I will present to you my viewpoint about the topic. I have no disclosures relevant for this presentation, and I will use the Esquivel reasoning, which says the more we know, the more we learn, the more we learn, the more we know, that there are things that we don't know. We know for over 130 years that intraperitoneal dissemination of cancer, as described by Dr. Paget, is a hypothesis of seed and soil. in which the soil is the peritoneum, and because of the presence of an extensive lymphatic network, great vascularity, and the presence of stem cells, this is a microenvironment favoring the installation of tumors. Dr. Sugarbaker, 110 years later, presented to us the peritonectomy technique to be able to surgically remove the intraperitoneal dissemination of this small appendage tumor. This requires an in-block resection of the terminal ileum, abdominal colon, the major omentum, and the tail of the pancreas and the spleen. During this process, there is a dissemination of millions of cancer cells. To attack this massive dissemination, Dr. John Spratt from the University of Louisville in Kentucky developed a therapy that combines not only chemotherapy, but also hyperthermia. This consists on a machine that is connected through two catheters, one to introduce warm chemotherapy into the abdomen and another to remove it and take it back to the machine so it heats up. The temperature is measured with two thermometers. And as you can see in this slide, you may have a very uniform therapy with degrees in the abdomen between 42 and 44 degrees Celsius. This temperature is cytotoxic for cancer cells. We also know that there is a pharmacological support for this type of treatment because there is a high concentration of the drug in the peritoneal fluid, which attacks the external portion of the tumor nodule. Part of that chemotherapy will be absorbed by the bloodstream. And through this system, we will also attack the internal aspect of the tumor nodule. We have been able to establish that the concentration in peritoneal fluid, in this case of mitomycin C, is 30 times greater compared to the concentration in plasma. Of course, concentration in plasma will determine the side effects, and the concentration in the peritoneal fluid determines the effectiveness of the drug. The following component, as mentioned, is hyperthermia. This slide is very important. This is the thesis by Dr. Roger Bultris from Galveston University, showing that temperatures between 37 and 40 degrees, if maintained for 6 hours in the peritoneal cavity, only cause fever. But if temperature reaches up to 43 degrees for under 30 minutes or 40 degrees for 6 hours, we don't really know what the effect of temperature is on tumor nodules. However, we know that there is a therapeutic window. That therapeutic window, I want to show you here, does not begin until after 30 minutes of temperatures of 43 degrees Celsius in the abdominal cavity, with a peak when that temperature between 41 and 43 degrees Celsius is maintained for over 2 hours. This is of utmost importance. There have been extensive publications of many retrospective series showing the results of this type of treatment. As you can see, there's a 5-year survival rate never described using systemic therapies. However, we cannot leave out a critical vision of HIPEC without speaking of the dichotomy between oncologic surgeons and oncologic physicians. This is analogous to the theories of Republicans and Democrats in the US. This study from the oncologic physicians, this is SWOG 8045, includes a high number of patients with metastatic colon cancer, not only with peritoneal disease. 1,140 patients with a non-muted KRAS and who are randomized to receive chemotherapy using cetuximab or chemotherapy using bevacizumab. The very impressive result is an average survival of around 30 months without difference between the two arms. The oncologic physicians can perform these prospective randomized studies because both arms include chemotherapy, and therefore there is an equilibrium between both arms. The studies considering surgery and non-surgery are much harder to carry out. The results of SLAGO were compared to the 5FU therapy, which had a survival of 12 months. And therefore, the oncologic physicians said, look, in 20 years, we've been able to improve survival of patients with metastatic colon cancer in a very important manner. And therefore, oncologic surgeons are still demanded showing prospective studies. Thanks to the direction of François Quinet, the French carried out Prodigy 7. The structure of the study was giving patients with colon cancer with peritoneal dissemination 3 cycles of systemic chemotherapy. If they had a good response, they were taken to cytoreduction. And after that, in the OR, they were randomized to receive HIPEC with oxaliplatin or no HIPEC. However, because of recruitment issues, the study was modified, and it was required that patients received 6 months of systemic chemotherapy. However, that chemotherapy could be before, after, or a little bit before and a little bit after, which in my opinion represents a problem from the point of view of design of the study. What we can even predict, and this is a slide I presented many years ago, is that Prodigy 7 would show the real role of surgery in patients with colorectal cancer with peritoneal dissemination. And the conclusions I reached at those days, it was that we should congratulate the French because they carried out the study and also because they won the World Cup in 2018. This really showed the value of surgery in these types of patients, and also showed that 30 minutes of hyperthermia, even with oxaliplatin, were not enough to improve survival in these particular patients. One of the problems, as I already mentioned, was that systemic therapy was not controlled, and there was no stratification based on the burden or the aggressiveness in the peritoneal surface. And in my opinion, it must be the end of HIPEC using oxaliplatin for only 30 minutes. Other studies we should consider are, for example, this one from the American Society of Studies of Peritoneal Cancers, performed considering 20 institutions in different countries, and considers more than 1,000 patients. We have 723 receiving HIPEC and 325 not receiving HIPEC, and survival in those receiving HIPEC was 4 times that of those who did not receive it. There is clearly an important difference and very high p-value, but I'm the first one who must clear out that this is not a prospective study, and it is obvious that those patients receiving HIPEC had a more extensive treatment compared to those not receiving HIPEC. However, the objective of the study was to demonstrate that all carcinomatosis are not the same, although they are created exactly as different. So carcinomatosis may be divided in one of 4 groups based on clinical prognostic factors, quantity of tumor, and especially histology. As you can see here, considering 308 patients not receiving HIPEC, those 10 months may have a variation of 5 times when compared with this severity criterion of the peritoneal surface, with patients having survival of 39 months with the score 1 and 7 months with the score 4. Considering 610 patients who were treated in a uniform manner, these are patients who underwent 1 complete cytoreduction, received HIPEC, and who are compared based on the severity score. As you can see, survival varies quite a bit between 27 and 81 months. something very important that should be taken into consideration. Something else we have learned is that experience plays an important role. Thanks to the French, once again, we know that before 1995, their overall survival was 6 months, and when they started selecting patients better and performing HIPEC, average or overall survival was 54 months. Applying the Esquivel reasoning and performing a sub-analysis of SWOG 80-45, we can also learn that, as I mentioned, overall survival was 30 months in those patients receiving chemotherapy with cetuximab. However, when we compare this group of patients only based on the site of origin of the colorectal cancer, those who had right colon cancer had a survival that was 3 times less compared with those who had left colon cancer, something that is tremendously important. We have also learned that in spite of all this knowledge, the impact of HIPEC in the treatment of patients with colorectal cancer with peritoneal dissemination is sadly that the impact is very low. Less than 5% of patients who are candidate to cytoreduction, to complete cytoreduction, have received this type of treatment. And this is true in the US, in Germany, and the UK. And although this slide says that in France it may be 20%, I think that today it's even less than 5% because it's very hard to carry out this type of treatment after the results of Prodigy 7. So we find ourselves with the fact that HIPEC is a solution looking for a problem. What I would like to say is that what we know is the following. HIPEC is a dual treatment modality. One is chemotherapy, another is hyperthermia, which is focused only on residual microscopic disease. This is the message I would like to give to you. What do we also know? We know what HIPEC is not. It is not a substitute for inadequate surgery. It is not permission to do massive cytoreduction in patients who have a high PCI index secondary to signet ring cells. It is not the last resource therapy. And I say it twice. It is not a 30-minute treatment. Once again, it is not a 30-minute treatment. As I mentioned in the Dr. Bertra's slide, the challenge we have today in the management of patients with colorectal cancer and peritoneal dissemination depends on the resectability and the quantity of tumor present and the recurrence and results of these types of treatments, which will depend on the biology of the tumor. The role played by surgery, and we thank the French for this, we know has been validated. There is a role for surgery in these types of patients, and there is also a role in those with liver metastasis. The role played by systemic therapy must be validated by the medical oncologist, and we hope that this is true in a close future, especially because staging of patients with peritoneal dissemination is stage 4C. HIPEC will continue to be used, in my opinion, but only for those patients who have residual microscopic disease, and the biology of the tumor will continue to be understood broadly once we perform the genomic profile analysis and the severity score of the tumors of peritoneal surface. So my strategy, the proposed strategy, is that for those patients with colorectal cancer with peritoneal disease are taken to laparoscopy. If not all tumor can be resected, they should be taken to systemic therapy, chemotherapy. If the tumor can be removed completely, we should remove the macroscopic disease. If you can take that patient to microscopic residual disease, we should use HIPEC, which in my opinion consists of 90 minutes of mitomycin C. And in spite of comments from other colleagues, I believe that there is no scientific justification that validates what is contrary to this proposed strategy. After the recovery of the patient, we should continue using liquid biopsies from the peritoneal fluid to detect those patients who have a molecular residual disease. And if this is the case and the liquid biopsy is positive, they should be taken to immunotherapy. Finally, I think that the solution is to work together with a medical oncologist in the moment that these patients are diagnosed. They should not be referred to the surgeon after 3 lines of chemotherapy, and that HIPEC and cytoreduction should be used as part of the strategy of treatment and not as a last resource strategy. Thank you for your attention, and I hope that we can have questions and answers in a later moment.
I'd like to thank the SLAGO organization to be able to share certain concepts on PIPAC, which is pressurized intraperitoneal aerosol chemotherapy. This technique has a goal to eliminate or decrease all the tumor influx in the case of carcinomatosis, which is reached in about 65%. There are other secondary goals such as pain palliation, management of ascites, dyspnea, nausea, vomiting, and to decrease the tumor mass that are not resectable to make them resectable. It is well tolerated, it's for short duration period and requires a brief hospitalization. Usually, this technique is used in ovarian cancer, gastric cancer, and colorectal cancer, and on many occasions has an only palliative character, or on some occasions in 5% tumor remission is reached. It has a better penetration in the tissues. There is a very homogeneous distribution. It's not being seen only in the patients, but also in experimental trials. They use lower chemotherapy dose than HIPEC procedures, and in all the this procedure, biopsy should be taken to see how the follow-up continues. There's a minimum systemic absorption and inflammatory reaction that is secondary to this PIPAC procedure. It's low and no toxicity in organs such as liver or kidney. Here we are seeing the technique. We will go into details later on. Basically, what we do, we introduce an element which is called camnopen, which delivers the chemotherapy at high pressure, so it becomes homogeneously distributed within the cavity. Low rates of complications, there you can see a percentage intra-op 3%, post-op 3%, and adverse effects 12 to 15% basically, and the most important one is the post-op pain. And the clinical response, as you can see, according to the different organs that are affected, ovarian, gastric, and colorectal mesothelioma from 15 to 91% of effectiveness. Survival goes from 8 to 27 months, depending on the cancer and its prognosis. How do we use PIPAC? The PIPAC can be used in 2 manners. Basically, this goes together with chemotherapy, and in 2 cycles, then PIPAC, and then another 2 chemotherapy cycles, then PIPAC, and so on and so forth. And this is done every 6 weeks. The other way to do this is to deliver it in an isolated fashion and treating ascites, and then a new procedure is done when the ascites comes back. Some contraindications, when survival expectation is lower than 3 months, when there is intestinal obstruction, and in the case that during the procedure we have lesion of any viscera, this should be suspended because the possibility to open this at any level such as circulating fluid, etc. Later on, we have an anaphylactic reaction to chemotherapy. That's another contraindication. Relative contraindications when there is extraperitoneal metastasis, echo, PS greater than 2, or major ascites. There are certain trials on course going on right now, but no randomized control trial are being developed. Hopefully, this will take place later on. There is variability, and it is difficult to assess in terms of the results and through the assessment analysis as resistant PCI. Even though these are important, the most important thing probably is to do a laparoscopy to confirm and calculate the peritoneal cancer, so PCI, and then reassess and that more than one procedure. If there are more than 20 procedures, are well tolerated. This is the case of a woman of 61 years of age with a prior history of a colon cancer with an extensive carcinomatosis and moderate ascites with the colonoscopy using the screen, a tumor lesion of 5 centimeters at 5 centimeters of the anal margin, adenocarcinoma with moderate differentiation with NRAS, BRAF, and KRAS negative. So she received FOLFOX chemotherapy, and she presented ascites with multiple hospitalizations. Later on, we switched the scheme to FOLFIRI plus cetuximab to palliate ascites and to improve the clinical response. You can observe here the surgery was not proposed for this. And this was a very difficult to manage carcinomatosis, and PIPAC was done with favorable follow-up during 7 months. And the procedure was, she was discharged and with a favorable result. Here in the picture, the PIPAC, the technique where you can see carcinomatosis with an operating room where everything is duly installed, all the protective measures are taken, and we need to observe this with the protection, especially of the patient. The trocars are introduced, and you can see we seal this, and the external area and the internal area, the patient is with the and here we can see the biopsy sample. This is routine. This patient has a colon cancer. Then later on it was demonstrated that it was an ovarian cancer for each of the sessions. Here is the Capno pen. As I said before, this is like a pen of what where through this pen, high pressure chemotherapy is delivered to all the abdomen, and the connections are being made. You can see they should always be safe. You can see there's a plastic in the left hand of the surgeon. Everything should be covered, so in case of leakage, this will not affect surgeon or patient. Capno pen is introduced through direct view. The other part is in the other trocar with the laparoscopy camera. Internally, you can see the introduction of the Capno pen. That's the distance. The introduction should not be too extensive. It should not be close to any organs to avoid collapse. And here we see the chemotherapeutic drugs, the platinum, etc. And you can observe it is covered by a plastic, so that in case of any problems on leakage, we can avoid contamination of the patient. Everything is covered with plastic. You can see one of the cameras is left outside, so it can be observed by the surgeon, and stitch is given by outside by the anesthesiologist who is giving the probe. Here in a remote fashion, the two drugs can be given: platinum diluted at 150 cc, and the other drug at 50 cc dilution. At different times, these two drugs are delivered, and during the whole time, the operating room is empty, and you are able to observe that the safety measures are complete. And fortunately, we have not had any problems in this area. Here, we can appreciate the injection of the drug. You can see the fluid coming out, and then you start seeing like those droplets, which are showing you the aerolization of the chemotherapy that is distributed homogeneously throughout the abdomen, reaching the faraway areas. So hopefully this is directly to the areas of more carcinomatosis. You can see that cloud is with a higher intensity kept for 6.5 minutes, when it's only one drug, and for this time when we have two drugs. This is done, this is left in place for 30 minutes, then air is extracted with a special filter, so all the safety measures are in place to protect surgeons and patients and everyone. And these are the important safety measures. Through this, we can close the orifices. You can see the fluid there, which is kept there, and in general, there shouldn't be any problems in terms of leakage or anything. In the diagram, you can see it on the screen once again. Connection to the machines, the camera, seeing from outside, and the injection through the capno pen. This is how we start the program. And this is the topic we've dedicated to the subject. We have gone through the initiation. We have a whole team dedicated to the topic. We have educated our surgeons, and we have protocols, and everyone has been education, and we are a recognized education center. We fortunately were invited to the Grenoble University. Dr. Ava, who was also invited to the station, he got some patients, he gathered some patients, and he prepared them for us, and so we were able to acquire the experience to take this program to our country. We presented this program to the direction of the clinic, and this was approved through a meeting with the medical director of the Clínica Las Condes. And then we made the protocols. They were highly inspired in the French protocols, of course, we must admit, with some changes related to our reality. We did a checklist, very strict checklist, so we did not go into any problems in terms of safety. And two meetings, all of us together, on separately: anesthesia, nurse, OR, chemistry, pharmacy, risk prevention, X-ray technologies that showed us how to manage diffusers, medical teams, to have adequate education, acquisition, to see the costs associated to this, everything that was needed for this, the company representatives. And finally, we reviewed the equipment and a video conference with France, with everyone present there, everyone who was educated and was going to participate of this PIPAC program. And with that, we achieved the final approval. We saw the doubts, the questions, and each person had the chance to state their doubts and had an adequate response to all their questions. After everything was implemented and we started our program, we had kept contact with all the physicians in France and to clarify doubts that came along the way, technical problems that we could face, to have that support. This has been our experience. It has been a good experience, I must say, and you can see it on the screen. 4 patients up to now, 8 sessions, one with cancer, the colon cancer, and I went afterwards to a resective surgery. 2 patients with colon cancer that had been kept with PIPAC treatment, and the indication was ascites. 1 female patient that we presented her with colon cancer diagnosis, but then we confirmed ovarian cancer, and that was good because we were able to switch chemotherapy. And 1 last patient with a pancreatic cancer, a young patient, 44 years of age, a physician, and he has been kept with PIPAC, and he is with chemotherapy, but a very well controlled disease. This is what we wanted to tell you about, and we'd like to thank the possibility to do this presentation. I'd like to invite you to the webpage, and you are communicating with our hospital, and I'd like to thank all the physicians that have participated and helped in this.